The chapter now is devoted to acquired heart disease. Because this is the surgical review, we're only going to touch upon those for which an operation is done. A 72-year-old man has a history of angina and exertional syncopal episodes. He has a harsh mid-systolic heart murmur, best heard at the right second intercostal space and along the left sternal border. You should be able to recognize that this is aortic stenosis. You know that we hear the aortic valve best at the second intercostal space on the right side. The murmur here is during systole, which means the blood cannot get out easily. There is aortic stenosis. You also know what to do for diagnosis, because remember, the diagnostic test for any morphological abnormality of the heart is an echocardiogram. And the indications for surgical intervention are either a gradient of more than 50 millimeters of mercury, or the first indication of congestive heart failure, angina, or syncope. This gentleman already has angina and syncopal episodes. He is already a candidate for surgical intervention. And as a rule, a damaged aortic valve cannot be repaired. As a rule, we replace it. So we're talking about a valvular replacement as the operation that this man needs. Now in begin number 10, we have a 72-year-old man who has been known for years to have a wide pulse pressure and a blowing, high-pitched, diastolic heart murmur, best heard at the right second intercostal space and along the left lower sternal border with the patient in foot expiration. He has had periodic echocardiograms, and in the most recent one there is evidence of beginning left ventricular dilatation. And that's the indication for intervention in chronic aortic insufficiency, which is what this patient has. And as we mentioned before, that aortic valve we will not typically be able to repair, and so a valvular replacement is what is called for. Now let me touch upon a variant of a damaged aortic valve here that has a different situation here. A 26-year-old drug-addicted man develops congestive heart failure over a short period of a few days. He has a loud diastolic murmur at the right second intercostal space. A physical examination done a few weeks ago when he had attempted to enroll in a detoxification program was completely normal. You know that one of the risks that the drug-addicted individual has is as they use dirty needles and dirty syringes to inject the drug, they may inject bacteria. They may end up with bacteria setting up shop in the heart valves and destroying them. Now, the valves that are mostly at risk, of course, are the ones on the right side, because the injection is typically intravenous. But those are less essential for normal function of the heart, and they would not have as dramatic a presentation as in the situation where it is the aortic valve that is damaged, which is what this vignette represents. So this man destroyed his aortic valve with subacute bacterial endocarditis, and now he needs an emergency valvular replacement as well as intravenous antibiotics for a very, very long period of time to make sure that new valve is not colonized by bacteria as well. Now we move to the mitral valve, vignette number 12. A 35-year-old lady has dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, and hemoptysis. She's had these progressive symptoms for about 5 years. She looks thin and cachectic, has atrial fibrillation, and a low-pitch, rumbling, diastolic apical heart murmur. At age 15, she had rheumatic fever. You look at all that and you know that's mitral stenosis. which an echocardiogram will confirm for you. Remember, any one of these vignettes we've read, the diagnostic test is echocardiogram. I'm going to say it again. If the problem you're confronting on the exam is a morphological abnormality of the heart, your test of choice is echocardiogram. Now, the indication for intervention for mitral stenosis, I cannot give you a precise finding. It's essentially when the patient is sick and tired. When the patient says, "Doc, I've been taking the digitalis and diuretics, I sleep with a bunch of pillows and I'm getting worse all the time. Isn't there something else you can do?" Yes, we can repair the valve, and the word repair is used advisedly here. Because whereas in the aortic valve we said if it is no longer functioning, we typically have to replace it. In the mitral valve, which we can replace if we have to, we would rather, if at all possible, repair the existing valve. Well, in this case, the problem is stenosis. The repair is done with a mitral commissurotomy. Let's move to the next vignette. A 55-year-old lady has been known for years to have mitral valve prolapse. She now has developed exertional dyspnea, orthopnea, and atrial fibrillation. She has an apical, high-pitched, holosystolic heart murmur that radiates to the axilla and back. This is mitral regurgitation. An echocardiogram will show you that. And eventually, repair of that valve will be indicated if the lady says, "I'm sick and tired, I'm taking all these medicines, I'm not getting any better. Can you do something else?" Yes, we can. And in the case of mitral regurgitation, the repair is what we call an annuloplasty. The mitral valve has two leaflets. They hang from a ring of tissue called the annulus. That annulus is dilated in this case, and those leaflets do not meet anymore. If we make that annulus smaller, we do an annuloplasty. Now the leaflets will close. And with that, we move now to the acquired disease that affects the coronaries. A 55-year-old man has progressive, unstable, disabling angina that does not respond to medical management. His father and two older brothers died of heart attacks before the age of 50. The patient stopped smoking 20 years ago, but he still has a sedentary lifestyle, is a bit overweight, has type 2 diabetes mellitus, and has high cholesterol. This is obviously a gentleman with a very high risk for a heart attack. But what makes this individual potentially a surgical candidate is the fact that his angina, let me read it again, is progressive, unstable, disabling, that does not respond to medical management. Otherwise, angina is treated medically, little nitroglycerin tablets. But this particular degree of difficulty should be evaluated to see if he can be helped with a repair. Now let's talk a little bit about how we evaluate the coronaries. This is a brief detour into radiology. If we need to look at blood vessels this big, the aorta, the pulmonary artery, a spiral CT scan will give us information we need. If we need to look at vessels this big, I already mentioned the renal artery. We already mentioned the femoral in somebody who had a gunshot wound nearby. We can do Doppler studies. We can do a particular test called duplex scanning, where we get the picture of a vessel and information about the flow. And everything we've mentioned so far is non-invasive. But when it comes to the coronaries that are very small, as of the time we're doing this taping, which is in the year 2007, we still do not have a reliable, non-invasive test that we can use to make our surgical decisions. Now, they are trying. There are technological advances all the time, and you even see ads for highly sophisticated CT scans that detect the calcium in the coronaries and so on. But as of the time of this taping, to make a decision for an intervention in the coronaries, we need a coronary angiogram, which means we need a cardiac catheterization to shoot the pictures that show us the coronaries. So this gentleman is a good candidate to have that cardiac catheterization for such evaluation. So let's move to the next vignette where that happens. I'll read you the whole thing, so we repeat again who is a typical patient who undergoes this. 55-year-old man has progressive, unstable, disabling angina that does not respond to medical management. His father and two older brothers died of heart attacks before the age of 50. The patient stopped smoking 20 years ago, but he still has a sedentary lifestyle. He's a bit overweight, has type 2 diabetes mellitus, has a high cholesterol. Cardiac catheterization demonstrates 70% occlusion of 3 coronary arteries with good distal vessels, and his left ventricular ejection fraction is 55. Let's analyze this. In fact, this man is an ideal candidate for intervention, because what you want that catheterization to show are 3 things. There must be stenosis of 70% or more in 1 or more of the coronary vessels. There must be good vessel beyond the stenosis, so there is a place to hook up to if you do a graft, or to have the blood go to if you do an angioplasty and a stent. But it's also imperative that the damage to the ventricle be minimal, because should the ventricle already be damaged by protracted ischemic episodes, you cannot resuscitate dead muscle. So if his ventricular ejection fraction were to be severely compromised, he would no longer be a candidate for revascularization. But as it happens, the number that I read on this man is normal. Remember, the normal ventricular ejection fraction is 0.55. So this man indeed is a good candidate for intervention. But we still have another decision to make. What kind of intervention? Because at one time, the only intervention that could be offered to a man like this was a surgical intervention, a coronary bypass graft. We took the internal mammary artery and used it as a graft for the most critical of the coronaries, the anterior descending. If other vessels had to be fixed, we used saphenous vein as a graft. But more recently, we've had tremendous development and strides on the field of angioplasty and stenting, which is now also commonly used for coronary revascularization. Now, I have to tell you, this is a disputed field, where the surgeons and the internists say we do the better job. There is, however, a general rule you can use for the exam. The simpler the problem, the better off you are picking the answer that says angioplasty and stent. The more complicated the problem, the more the indication swings to the side of coronary bypass graft. If this man had had in the cardiac catheterization not 3 vessel disease, but 1 vessel disease, and that vessel was not the most critical one, the anterior descending, he would have been a perfect candidate for angioplasty and stent. Because he has 3 vessels involved, he needs the surgical intervention. The next 2 questions give you numbers that you need to evaluate to come up with an answer. Let me have a little bit of a background prior to that. Throughout the USMLE, there'll be numerous instances where you're given laboratory values on a patient. And the USMLE very kindly does not expect you to memorize the normal values. You can ask for them. The USMLE, on the other hand, doesn't give you normal physiological parameters. You're expected to know those. So we're going to quote some numbers now in the next two vignettes that you cannot push a button on the computer and say, I need to know what the normal is, like you can do for the lab tests. Let me read the first one. A postoperative patient who underwent open heart surgery is determined to have a cardiac index of 1.7 liters per minute per square meter and a left ventricular end diastolic pressure of 3 millimeters of mercury. Let's see what this means. By the way, this is a kind of determination that we do several times a day in that coronary care unit where we have the patients who just have undergone open heart surgery. So the first data we're giving is cardiac index. Cardiac index is cardiac output expressed per square meter of body surface. So let's remember two important values. In a normal average size adult, the normal cardiac output is 5 liters a minute. But if we use a value that determines the output by square meter of body surface, an average size adult is roughly 1.7 square meters. So the normal cardiac index is about 3. So let me repeat. Normal cardiac output, 5. Normal cardiac index, 3. And we're told this patient has 1.7. So the first determination we've made is he doesn't have enough cardiac output. Being as it is a postoperative patient who just had heart surgery, there are two possibilities. He doesn't have enough fluid. He doesn't have enough blood volume. He has not been given enough fluid to have a good output, or his ventricle is failing. If he doesn't have enough fluid, the pressures in the right side of the heart and the left side of the heart are going to be low atrial pressures, low end diastolic pressures. If he were failing, on the other hand, those pressures would be high. Well, one of the pressures we can measure is end diastolic left ventricular pressure. Actually, we do that not by having a catheter in the ventricle. A catheter has been inserted in the jugular vein. It's gone down to the right atrium, right ventricle, out the pulmonary artery, and gets a wedge. And when we read that wedge pressure, we're reading pressure from the left atrium. And if the mitral valve is normal, that is also the left end diastolic ventricular pressure, which should be in the neighborhood of maybe 10 or 12 or thereabouts. And we learned that in this case it is 3, low. So the bottom line is, in this particular case, this patient needs more fluid than we've been giving him. His cardiac output is low because he doesn't have enough vascular volume. Let me read the next one to pursue the same topic. A 72-kilogram patient who had a triple coronary bypass is determined on the second postoperative day to have a cardiac output of 2.3 liters per minute. His pulmonary wedge pressure is 27 millimeters of mercury. Let's look at those numbers again. Now we were told cardiac output rather than cardiac index. But we were told this is a 72-kilogram person. So we know a person of that size should have a cardiac output of about 5 liters a minute. He only has 2.3, low cardiac output. We are again presented with a differential diagnosis now. Is it because of insufficient fluid, or is it because the ventricle is failing? Well, we are giving in this case a pulmonary wedge pressure, which, remember, is the same. Pulmonary wedge pressure is what we could also say this also reflects left atrial pressure. This also reflects left ventricular end diastolic pressure. And the normal ought to be around 10 or 12, and we find that it is 27. So what we have here is not the need for more fluid. What we have here is a failing ventricle. And this patient needs help in that direction. Ionotropic agents, perhaps even a mechanical device to help with the cardiac output that his own heart cannot produce. We have a few pictures here to illustrate some of the topics we have talked about. You have a depiction here of aortic stenosis, a normal aortic valve on one side, and what in this case, in fact, would be a congenital anomaly that has only 2 leaflets instead of 3. Stenotic aortic valve. And we have also schematic representation of a mitral valve prolapse, which is now commonly what leads to mitral regurgitation. And that's the end of acquired heart disease.